Before we start discussing the topic of low flow anesthesia, can anyone tell me how many of you use frequently low flow anesthesia? Or anyone who is using low flow anesthesia? Anyone, please. Nobody's using low flow anesthesia? Nasrullah bhai, do you use low flow anesthesia?
Assalamu alaikum, Dr. Zishan.
Yes, sir.
Dr. Zishan, honestly speaking, एक तो मैंने sorry, I haven't touched the topic today. Number one.
No problem.
I was
Practically speaking,
yeah.
practically, do you
speaking,
use low
yeah,
flow anesthesia?
I am using minimum. I have until now I have used 1 liter of gases, 0.5 oxygen and 0.5 liter of air. I have used since many years.
Okay, so maximum minimum flow which you have used is 1 liter. Anyone less than that?
Internationally recommended is 0.5 liter.
And I will not say recommended, but you say that when you are using the concept of low flow anesthesia, you can go up to even the metabolic flow. What is metabolic flow?
Metabolic means maybe the metabolism of the gases like desflurane, minimal metabolism of the gases.
No. Nasrullah bhai,
In the liver, no?
No, it's not that. Just think about it.
Okay.
How much is the oxygen requirement in the body?
Yeah, 25%.
25%. Not in that way. How many mLs per minute oxygen is being utilized in the body?
250 ml. 250
Yes.
ml from 1000. Yeah.
Roughly
Oxygen flux.
exactly 3.4 ml per kg. Okay. So to be
Okay.
exactly, it will be around, you can say, as metabolic flow. But of course, first of all, it will just be practically what is the advantage of low flow. Okay, and then we will just see some text what is all about. I will just try to tell the practicalities, because actually I am using since at least 1 to 2 years. I am using this low flow anesthesia frequently, and it's an it's an amazing feeling. But what are the advantages? First of all, it is cost effective.
Shall I
Yes.
know? Shall I explain which few advantages I know?
Yes, please.
Is it
Go
okay?
ahead.
Number one, it is economical.
Okay.
And number two, it reduces the pollution. And also number three, these are the gases used by the patient having we can say the humid gases.
Very
Is
good.
it okay?
Yes.
And humid and warm gases.
Yes, because whatever is coming out is rebreathing. Okay. So it's a closed circuit. So actually the humidity, because the soda lime reaction, if we just recall, the reaction which occurs in soda lime is producing water. So usually if we are using a high flow, actually it is all dried up. Okay. So we are not getting that advantage. But if we are using very low flow anesthesia, around 500 ml, okay. So actually we are having this facility that automatically it is causing humidity. Okay.
Yeah.
So these are actually you have almost told a number of things. Few things maybe left: cost effective, economical, pollution, humidity, and actually what is the advantage is
Sorry,
that
can I ask a question?
I'm sorry.
Can I ask a question?
Sure.
So please explain this humidity again. I don't get it. Why in low flow are they more humid, and why if there's higher flow? Because it is a closed system, it's a closed circuit. So why does it matter?
When we are giving high flow, okay, so actually the extra gases are going out, okay.
Yes.
So actually it is causing the dryness because in the pop-up valve, or every time something is being lost out of the circuit because of the excessive flow which is going on. But when we are
Okay.
having a low flow, okay, so actually usually from where the gas flow out of the circuit, there are two places usually. One uh, from the APL valve, okay, when we
APL
are
valve.
having the spontaneous ventilation, and one the similar pop-up valve is there from the ventilator, okay, where the excessive,
Okay.
for example, if we have you open the flow at 10 liters, okay, so every minute
Yes.
everything will be washed out. So actually the humidity, the water which is produced, the humidity which is caught in the circuit is going out.
Okay.
So that is why it will not be able to have the to have that effect. Okay.
All right. Okay. Thank you.
Okay. So whenever we are using such thing, we should be knowing what are the prerequisites. Okay. Because whenever we are using a low flow anesthesia, what is happening that the fresh gas flow is coming. Usually it is if you are not using it around 4 liters total flow, okay, so everything is being lost. When we are having very low flow, right, like I'm just giving an example with 500 ml. So if we are giving only 500 ml, it is 500 ml per minute, for example, okay. So what is happening that um, the expired gas which is coming is diluting actually the fast gas flow. I will try to write as clean as possible. So the expired gases are diluting the fresh gas flow. Like for example, it has some carbon dioxide, okay? It has a less concentration of oxygen. So when they are mixing it with it, yes, CO2 will be removed by the soda lime. But this low FiO2 mixture will be mixing with the fresh gas flow. So the amount of oxygen which was there in this fresh gas flow will be diluted. Say, for example, we are giving 30% oxygen, but the mixture which is coming out is having only 20, for example. I'm just giving an example. So it is 20%. So when these two mixtures will combine, this will not remain 30%. It will may become 25%. Okay, so this will be one effect. And similarly, there are other trace gases which will be coming, and even, for example, any patient, which, for example, methane, uh, if patient is alcoholic, okay, or anything like that, which is patient is expiring, can be increased. So it is actually diluting the mixture. So this is one effect. Then again, the fresh gas flow is having a certain percentage of volatile anesthetics. When again it is coming out, it is mixing. So if we are put at dial at 1%, the actual amount which is going inside the lungs will not be 1%. It may be decreased. So for that, there are certain prerequisites. So agent analyzer is the prerequisite. We cannot perform low flow anesthesia if we don't have an agent analyzer, because we have to make sure what FiO2 we are giving. We have to make sure what end tidal O2 is coming out. Okay. Then we have to see, of course, end tidal CO2 and end tidal inspiratory CO2. Inspiratory CO2. Okay. Because this is important. Then because of rebreathing, okay, and if we should have telling the this inhalational agent concentration. Okay, inhalational agent concentration, because I told you that it is diluted. So for example, if you don't have the agent analyzer, you cannot see in this low flow how much percentage of volatile anesthetic you are giving. Okay, so if you want to be sure, you should have agent analyzer. Then you should be knowing what is happening, because certain steps which are occurring initially, if for example there is a concept of developing the MAC value. Okay, developing the just give me a second. I'm sorry. Yes. So actually, when we open the circuit, we start the ventilation. If we have a flow of, for example, 4 liter, I hope you are getting what I'm trying to make you understand. Because if you don't understand, then you cannot use it. So, for example, if you have open a case with 2 plus 2, 4 liters total flow, and you have put the dial at 2%, okay, and now you will be achieving the levels in, for example, I'm just giving you example, in 2 minutes. Okay, because how much it is the concept of time constant, that in how much time you are achieving the MAC. Okay, so now if for example your flow is only 0.5 liter with the same 2% sevoflurane, you will take at least 3 to 4 times more time. For example, if you are taking 6 minutes, 2 minutes here, maybe you are taking around 7 to 8 minutes to achieve the desired result. So if you open it and you are having a low flow anesthesia to initially, maybe the depth of anesthesia will not be achieved. So you should be knowing that initially, whenever we are performing this low flow anesthesia, initially we prime the circuit. Okay, we prime the circuit with slightly high flow, and then when we keep on seeing the agent analyzer, and when we achieve the MAC, the required MAC, like around 1.2 or 1.3 or whatever MAC we are targeting, then we can slow down with the flow. Okay, and then whole of the gas will be caught inside, and then you can maintain it, keep it throughout the procedure. And same step will be required. Like for example, if you are maintaining a MAC of 1.2, and now patient suddenly is in hypotension, and if you want to decrease the MAC, you cannot achieve it quickly unless you increase the flow. So whenever you are using this concept of low flow anesthesia, you should be knowing that any change which you are doing will take much more time than normal. I hope you understand. If you don't understand, please ask me. Nasrullah bhai, do you understand? Okay, so like for example, if you are having flow of 500 ml and you are maintaining a MAC of 1.2, if you want to change it, if you suddenly patient is in hypotension and now you want to come decrease the values, only decreasing the dial will not solve this problem at that time. Okay, you will need to increase the flow. So that's why whenever you are using low flow anesthesia, you should be knowing how it works. Otherwise, you will be in trouble. Similarly, as I told you, that maybe you have open FiO2 of 50%, but maybe after some time you are seeing that the actual FiO2 which is delivered maybe only 30%. Okay. So that is the concept that you should be understanding before performing low flow anesthesia. So because the volume of gas, the volume of inhalational agent which you are using is massively decreased. Maybe if you are using a flow of 4 liter and you are consuming, for example, I'm just giving you example, maybe 50 ml over 1 hour. So if you are using a flow of 0.5, this will be drastically decreased. Maybe you are only using 7.5 ml. So just imagine how much you can save. So this is very economical, but you should be knowing the prerequisites, the monitoring required. So you should be have the concept of how how we achieve the MAC. So for MAC, one of the factor is fresh gas flow, one of the factor is dial concentration, one of the factor, of course, is alveolar ventilation. Okay, and then according to the dynamics of that agent as well, because as much low the blood gas partition coefficient will be, as faster that will be uptake by the at slow they will be uptake and the MAC will be achieved quickly. So you should be, when you are thinking about the concept of low flow anesthesia, you should have a thorough concept of how the inhalational agents work. Okay, so just we will just try to have some. I had downloaded some of the material related to it. Just a second. Okay, so these are the advantages. We will just have a look. Preserve heat and humidity of spire gases. Okay, body temperature and reduce water loss. Improves the flow dynamics of inhaled anesthetic gases. Increase mucociliary clearance. Improves airway epithelial health. Reduces accumulation of dried airway secretions. Economical, reduce anesthetic gas consumption. Significant saving of the order of 60 to 75% with regard to volatile anesthetic agents. And of course, the fluorocarbons and the ozone layer, the greenhouse effect. Okay, reduced greenhouse effect due to nitrous oxide and volatile agents. Environmental, reduce operation room pollution. Okay, so these are the things, and these are certain definitions you will find slightly maybe different levels in, but usually around 500 ml is the low flow. Okay, and metabolic flow, as explained to you, that usually in adult it is around 250 ml per minute. Okay, one few things I just forgot to mention. One of them was that when you are having any leak in the circuit. Okay, so if it is more than 100 ml, so if you are giving only 500 ml and you happen to lose around 200 mils of volume, so it will have a big impact. Then similarly, if you are using side stream and tidal CO2, okay, itself it will be a problem, because side stream will take a lot of volume. So there should be a mechanism that the volume which is taken should come back. Otherwise, it will create problem. Okay. So similarly, if you have leak in the circuit by even with the uncuffed endotracheal tube or supraglottic airway devices, if it is not properly sealed, then you will lose this benefit. Okay. Can you please mute your mics, please? Okay. They are just saying the same thing. Gas monitoring, providing inspired and tidal concentration of agents, and vaporizers capable. Yes. Another thing is that usually vaporizers are calibrated to a wide range of flow, but we have to make sure that the vaporizer is properly calibrated to low flow, because otherwise they will not be able to have this accurate fraction, okay, which they are delivering. Breathing system should have the minimum internal volume to minimize the reserve volume. Okay, so disadvantages, we have the lower, as I explained to you, that there is dilution of anesthetic agents, low fresh gas flows are added to significantly high flow consisting of breathing tubing, a reservoir bag, and a static ventilator. Okay. In addition to FRC of the patient, hence the rate of change of composition of gas in the reserve volume is exponential, which is related to the time constant. It requires 3 time constant to reach around the calculated by the reserve volume. And actually, this was that total circuit volume usually is around 6 liters. And we divide, for example, if we are giving a flow of 1 liter. So one time constant will be 6 liter divided by 1 liter. So it will be 6 minutes. So for 3 time constant, it will be 18 minutes. Okay. I will just try to write it down so that you understand that if you have a 6 liter 6000 ml flow, total volume of circuit, and you are giving 1 liter, so it will be 6 minutes for one time constant. So it needs one time constant is around 63 and two time constant is I think around 70 something, and three time constant it reaches around 95%. So imagine that if you are having low flow, you will need more time. Similarly, if you just change this with, for example, 6 liter, so it will only become 1 minute. So you see, only in 3 time constant will be only 3 minutes. So you will achieve, if you have a flow of 6 liter, you will achieve the target within 3 minutes, as compared to if you have a flow of 1 liter, it will take 18 minutes. Okay. So that's what is written here. However, once steady state is achieved, low flow anesthesia provides the most economic use of anesthetic agents. So it is not very suitable technique to use in very short procedure lasting for only 15-20 minutes or half an hour. If you are using it in a slightly longer procedure, it is much more beneficial. Similarly, one more point, that oxygen consumption remain same throughout the procedure because it is the body requirement. But the requirement of nitrous oxide, because it's less soluble, and similarly the volatile agents gradually decrease when the body is like when we achieve a certain MAC, then UL uptake is decreased, the requirement is decreased. So we have to adjust accordingly. Okay. So similarly, differential uptake of agents modifying the composition of gas mixture. This effect is particularly important while combining nitrous oxide as a carrier gas because of its second gas effect. Okay, uptake of nitrous oxide is high initially, followed by gross reduction in its uptake. This change in the trend is differential uptake may lead to hypoxic mixture being delivered. Okay. Similarly, if you don't, the same thing will occur at the end of the procedure. So if you want, like I do, that maybe before, and when I know that around 15 to 20 minutes, or even sometimes even I close it 30 minutes before, and I'm following with the MAC value. So usually it takes, if you did not increase the flow, actually it takes even half an hour, more than half an hour, it can remain before it comes below 0.8 or so. Okay. So this is all experience. Of course, you should have an experience to do it, because otherwise, if you don't do it, actually, you will not get that result. Okay. So if you close it later on, then there are options that you can increase the flow, and then actually the whole gases will come out. So actually, practically, you did not follow your goal. This is one thing. And there will be pollution at that time. So actually, if you want to use it tactfully, after few cases, you will understand that you just have to follow the monitor with the MAC, and you are just playing accordingly. If the MAC is going down, you will increase the flow or increase the dial concentration again, so that it develops and you don't create any awareness. Okay. Similarly, if you are using low flow anesthesia, or if generally, because midazolam is a medication which can cover you, and it is decreasing the MAC value even, and it prevents from awareness. So Actually, midazolam should be used much more frequently than we usually use. People are afraid of delayed recovery. But if you are using it tactfully again, midazolam is an excellent medication. Okay. So yes, similarly, this some challenges will be there if you are using in pediatric population, because usually this is uncuffed and there is this is sample connections, filters, and heat and moist exchanges, catheter mounts. So there it may be more challenging in pediatric population than adults. Okay, so as I told you, initially use high flow and then pre-filled circuits. Pre-filled circuits actually is a thing that they told that you can use other circuit through the outward flow for pre-oxygenation, and in that time when you are inducing the patient, actually you can have this the circuit which you will be using, the closed circuit, to prime it. You can do the same thing with the initial high flow, like you can open sevoflurane at 8, and then as soon as you achieve the MAC, you can close it or decrease the value. Okay. So usually there are a lot of apprehensions by the old people, the senior people actually, who have not in their era when there was no not much frequent availability of this agent analyzer, and so they are hesitant. So but actually even I started a few years ago and I'm enjoying it. Okay. And in some machines there is automated system in which they automatically calculate according to the body demographics, and then they tell how much flow is needed. So that is another way in some machines. Okay. So that's what I just wanted to discuss today. We will just continue our discussion related to low flow anesthesia, and then I will just in subsequent session I will just try to have discussion related to humidity, um, induction with the this closed circuit, soda lime. Okay. So the summary of the topic is that low flow anesthesia is an excellent technique with a lot of advantages, but you should be knowing how it works and you should be knowing the prerequisites. Otherwise, it can create some problems and challenges. Okay. So I will stop here. Anyone wants to ask any question or any comments?
Yes, Dr. Zishan, I have a question. The material which you have taken this, which is the book
Actually,
you
this is an
have?
article. This is an article I will share. Okay.
BJ, is this a BJ?
No, no. This is from Indian Journal of Anesthesia. This is
Okay.
okay.
Can you
Low flow
share this
anesthesia.
article in the group, please?
Sure, sure, sure. I will
Thank you.
um
Thank you, sir. Thank you
I
very
will
much.
upload it and I will share. Actually, I have got this subscription of a script slide share. So anyone wants any presentation, I can help, because I have taken this subscription and anyone can be benefited. Okay. So
Thank you.
Dr. Zishan, Assalamu alaikum.
yes, walaikum assalam. Yes.
I have just want one thing clear regarding metabolic flow. As it was
Yes.
written and you said it's 250 ml per minute.
Yes.
So there's a total fresh gas flow. So our body requirement, oxygen is the 250 ml per minute, only oxygen.
Yes.
So when we are giving, for example, mixture with the gases, air even, so that will be the decrease. I'm not clear about this point. So how the
No, no,
metabolism will occur because our normal
your
body required 250 ml.
yes, your point is absolutely valid. Actually, I think because this will be the fraction of oxygen which will be going. Like
That was
for
written
example,
FG, fresh gas flow, or fraction.
because how much is the tidal volume? You are mixing it one thing, that how much usually is the the concept is that this 250 ml we are replacing every minute. Okay, because we say that 250 ml per minute is the oxygen consumption. Okay, so actually in each minute 250 ml increased volume is going, but the volume which is there is already there. You understand? Because don't mix it with tidal volume. Tidal volume is separate, because every minute the patient is receiving the adequate tidal volume. Okay, so I hope you understand.
Thank you.
Okay. Okay, so thank you very much for all of you to attend, and all the recordings are there, because actually the basic sciences portion was missing before. Okay, so I will be trying to, because basic sciences you yourself has to read a lot to clear the concept before you are able to discuss it. So any volunteers who are preparing for the exam with fresh knowledge, just do contact me. I will be really thankful. Okay, so you will find it in the playlist of physics equipment here. Okay, here you will I will gradually put all these topics here. Before we had some discussion of some of the topics, and I will just try to build up this folder. Okay, so the rest of the topics are already there, and the people who from international speaker, the international people, this is the folder having all the discussions which are being done in English, because some of the discussions are done in our native language. So and there was a gap for a few months. Okay, so okay. Oh, I'm sorry, the screen was not shared, so I will just repeat it again. And this is the folder in which all the discussions which are being done in English are saved. Okay, and um, uh, this folder, uh, just a second, this equipment folder, I will put all the discussions in coming days. I'm not sure I will be able to do it daily, or because I need to prepare some points, find out some source before doing it. So thank you very much. Inshallah, we will meet again. Bye bye.